Good morning and very warm greetings from AIIMS Bathinda. And at the outset, I thank Dr. Vitull Gupta that AIIMS Bathinda is associated with MAPICON, and this is the second MAPICON here, although he's a little bit disappointed, and he has shown his disappointment, and I'm sure uh, from next time onwards, we'll be more careful. Coming back to rationale of minimal invasive coronary artery bypass grafting, uh, this is what I said. I will not speak on verses. My topic was angioplasty versus reverse coronary artery surgery. I said it's not verses. For me, CT cardiothoracic surgery program and cardiology, they are integral part. In corporate parlance, it may be that it's always versus, but I'm thankful to my colleagues. I'm thankful to Dr. Shiba. We worked together for a long number of years, and she has done a great job while she is presenting a data. So what I have done here as a team leader and what we have achieved in AIIMS, that's what I'm going to share my experience. Because surgeons, they are not good speakers. Their knowledge is very limited, but they tend to do the things which are a little bit different. So coronary artery disease, as Shiva was telling, it's a huge burden both in male and female. And one of the traditionally approach is either you do angioplasty or a gold standard for a surgeon is you do CABG. But finding a scar in the center of the chest, it's a huge psychological problem. It's a huge psychological stigma, which we all experience sometimes from the patient, from the society. So with advances in surgical techniques, and it led to the development of minimal invasive surgery over a number of years. It takes a lot of time to master the art of doing on-pump beating heart surgery, and it takes more time to do minimal invasive surgery. So what is the rationale behind mix or mid-cap CABG? So what about traditional CABG? You open the chest, there as shown in the diagram, you open the chest, you open, heart is in front of you, you practice and you do on beating heart. And what about mixed surgery? It's basically left anterior thoracotomy incision from on the left side, from the fourth or fifth intercostal space, you approach the heart, you can do anterior vessels or you can do lateral vessels. So again, traditional surgery, I say you have to split the sternum. But problem is sometimes patient even after surgery, you have put arterial grafts or venous grafts, your grafts are patent, but still they'll keep on complaining that there is a chest pain. But in diabetes and obese patient, there is 2% chances that sternum will be unstable or there will be sternal infection. Minimal invasive surgery that overcomes these problems because you are not splitting the sternum and surgical trauma is less. So how in 1960, first CABG was performed where left internal memory artery was grafted to LAD by a Russian surgeon. Then Brazilians came up with the multiple grafts. Over the year, techniques are being refined. And what I say now is that 30% your work is in an operation theater, 70% of your work is in post-operative area where you have to take care of that. So the drive towards less invasive surgery really began in 1990s. Like maybe that what I was given the topic versus pushed each of us, cardiologist doing more stenting or surgeon doing more minimal invasive procedures to attract. So technological advancement in instruments, imaging and robotic assistance led to the rise of mixed CABG. The evolution represents a paradigm shift in surgical thinking, moving away from open heart surgery procedure that avoid opening the chest entirely. So what are the rationale now? We avoid surgical trauma. Surgical trauma is less when you do minimal invasive surgery. There is decreased risk of complication, especially in diabetic and obese patients. Recovery time is faster. You can send a patient home on fourth or fifth day, whereas with the traditional approach, yes, you require 7 or 8 days when they get discharged. And cosmetic outcomes are certainly better. So what are the indications? Still, as per my experience, our experience is of 20 patients. What we have done is, on the left side of the heart, we have put grafts. But if you ask me, absolute indications are when there is a single vessel or multivessel coronary artery disease. We have still not touched the right system, particularly left anterior descending involvement. Then you must offer mix. Patient with high-risk factors that may complicate sternotomy, like obese patients, diabetic patients, elderly patients, patient with COPD, patient with chronic kidney disease. These are the patients who require minimal invasive surgery. Or maybe redo surgery. Initially, you were put a saphenous vein grafts in an emergency over the left anterior descending artery. Now that graft is blocked. Then again, you can offer, because it's LADs on the lateral surface of the heart, and from the fourth intercostal space on the left side, you can approach it very well. And another, the hybrid procedures are coming out. Suppose there is an inferior wall infarction. You take the patient to the cath lab. You open the culprit vessel, like right coronary artery or obtuse marginal artery. LAD is still there. So that with the hybrid, this thing, after a couple of days, you want to give a complete revascularization. You can osteal proximal LAD, you can do the minimal invasive surgery and send them home. So again, the role of hybrid coronary revascularization in mixed CABG. See, it's you need a very durable treatment for the patient. Putting lima, left internal memory artery, to LAD, we know from historical aspects, or we know from the data, that 95% of the patients, lima to LAD is open even after 20 years. That is the latest data. In 98% of the patients, after 10 years, lima still remains patent if you put on a left anterior descending artery. So treat the non-LAD lesions with stenting, and leave LAD lesion, which is osteoproximal, which is very tight or calcified, for a surgeon to do mixed CABG. Even in high-risk surgical candidates, those who are in shock, you stabilize the patient, you do hybrid stenting, and then leave other vessels for surgeon. So what are the benefits for hybrid procedure? Again, enhanced recovery in the form of reduced ICU and hospital stays, lower complication rates as compared to traditional CABG. And there are studies which proved the efficacy of this strategy. What are the contraindications for mix? Absolute contraindication is if left subclavian artery is occluded, because then you will not get lima and that advantage is lost. If patient is in cardiogenic shock with a LAD as a culprit vessel, then yes, it's contraindicated. What are the relative contraindications? So suppose the vessel is very deep in the muscle. There's the intramyocardial vessel, then don't go for minimal invasive approach. If it's a diffusely calcified vessel and the size of the vessel is less than 1.5 millimeter, then don't go for mixed CABG. Severe PAH, if it's a cardiogenic shock, even you have put a balloon pump and you have stabilized the patient, still pulmonary artery pressures are high, and there is a enlarged ventricle, don't go for this approach. If there is a previous thoracotomy and there are extensive chest lesions, then don't ever attempt this mixed CABG. And morbid obesity is again a contraindication for this group of patients. Now, just elaborating what are the mixed surgical procedures being performed, either from the right anterolateral thoracotomy, like you can approach mitral valve surgery, tricuspid valve repairs, ASD closures, atrial tumor resections, via upper partial mini sternotomy. It's a hemisternotomy. You are not opening full sternum. You can do aortic valve surgery, thymectomies, Via lower partial mini sternotomy, we can approach mitral valve, tricuspid valve, or ASD closures. From left anterior lateral mini thoracotomy, which is the incision which I am going to show the pictures, you can do CABG. Subxiphoid incisions, I think it's rarely being used for inferior wall vessels, and the results are not that good. So this is the, again, a diagram which will depict that on the left side. If you see, there is an incision which is 4 to 5 centimeter incision on the 4th or 5th intercostal space. Depending upon the approach to the LAD, you open from that space and you can approach and do the grafting. So we put external pads. If there is any shock to be given, because big paddles you can't accommodate from the small incisions, you can externally defibrillate them. So this is a position. It's a little left lateral position with 40-degree tilt of the patient, and we have put a mark just below the nipple. And that blue line, one blue line, is showing that it's a mid-axillary line. In the next diagram, you see the mid-axillary line. You have to remain away from the mid-axillary line. This is the position. So after opening the sternum, it's just a diagrammatic representation. You see the relationship of various structures at first intercostal space. So left intermammary artery goes laterally away from the left phrenic nerve, and it's a branch of left subclavian artery. So these are the traditional instruments, scopes, which are being used. But I'll show you what jugaad, because we don't have scopes, what Punjabi jugaad we have done while doing these surgeries, because it costs around about 1 to 1.5 crores to buy these instruments. So these are the scopes from various spaces where we can do minimal invasive surgeries. And what we can do without scopes also, where directly we open the chest and we can do surgeries. So this is one of these we have opened from the 4th intercostal space. Lima is being harvested.
Balloon again?
Yes, sir.
So in the next, again, it's showing that if you see that we are putting clips and taking down the Lima, left intermammary artery, because it is the graft which should be used for left anterior descending arteries. So now you see the epicardial fat. This is the fat which gets deposited over the pericardium. Sometimes it gives us more trouble. Pericardium is being opened with a cautery. I'll just show you. And you have to open the pericardium over the pulmonary artery, main pulmonary artery. So space is very less. You can't open more than that. The less you open, the less is the trauma in these patients, and faster the recovery. So in this patient, there was a lot of epicardial fat. We keep on eating sugars. We tell our patient not to eat sugars, eat less salt, but this is the result what we see. So this fat is being removed, and yes, now we have opened the pericardium. So we don't have these traditional retractors. What I have done is there are Thompson retractor available in general surgery or our other groups like gastrointestinal surgery. So I've used those smallest pads which, so we have opened the chest now. So you will see heart is beating, and we will approach the left anterior descending artery. So once you stabilize the heart, you see the vessel is being opened, you see the blood coming out of the head. We are opening the vessel further, and we will put a shunt in this open vessel, so to facilitate the grafting. So we are making a big incision and we are putting a shunt. So in the next picture, we are taking sutures. Sometimes flow is so much that that shunt comes out. So you see that we are suturing the vessel over this. So anastomosis is being completed. So this is the complete anastomosis. We have put left internal memory artery over the left anterior descending artery. This is the final this thing. So this is again once in one of the females we were trying to take down the lemma, but lemma got injured. Then what to do? We took a vein. You see this there is a we have put a clamp over the aorta. We put the proximal vein over the aorta and did grafting with vein over the LAD. So this is again graft showing anastomosis of the graft. So these are the as I showed you in the picture, a small incision on the left side on the fourth or fifth intercostal space, you harvest intermemory artery, and you do surgery on off-pump surgery. You are not using any heart-lung machine, so you are reducing the risk of stroke because you are not touching the aorta. So there are scopes available which we don't have. In the coming time, we will go for the scopes where you can harvest the left internal memory artery with this scope, further reducing the trauma. So what are the benefits? There is a low risk of infection, reduced blood loss which we have calculated is close to 200 to 200 ml during surgery, whereas in the traditional surgery when we do after opening the chest, sternum, loss is close to 500 ml, that is the average loss. Faster postoperative recovery, we can extubate the patient within 4 hours. Improved, and more than that is there is an improved patient satisfaction because scarring is less, complications are less. So this is if you match on my left is traditional scar, which is central scar, and on the left there is a mixed scar. That's the difference. So outcomes are good, but you need a steep learning curve. It definitely improved quality of life, and there is a data, initial data up to 5 years is available. We have to still go what are our results because it's only 6 months when we have started. We have done around about 20 cases, and in female we have done 3 cases. Why we don't go for more female is because one is obesity, second is you have to respect the breast. Because breast sometimes if breast is heavy, then you can't cut the breast because you have to reflect the breast up. So what are the technological advancements? You need specialized instrument, long instruments. Still we are doing with the traditional instruments. A robot will ease your life. Hybrid procedures, yes, definitely we should go for hybrid procedures. And future technologies like 3D imaging will help you, artificial intelligence will help you. So what are the challenges and limitations? Learning curve is a very steep learning curve. First you learn to do the bypass on pump, then off pump, then you go for mix. Right patient selection is very critical. Not all patients are suitable candidates, particularly with complex coronary artery disease and who require valve surgery or who require combinations of procedure, don't go for it. In mix, in the initial period, there is an increased operative time as compared to when you have to put 1 or 2 grafts after opening a chest from standard. So with the passage of time, the time decreases. And more than that, there is a very limited access while doing mix. So you need a steep learning curve. So I'm concluding that mixed CABG provides a compelling alternative to traditional CABG for appropriately selected patients, offering reduced trauma, faster recovery, and excellent long-term outcomes. So as the technology will advance, your results will improve, you can cover more patients. So mixed CABG is a breakthrough in cardiac surgery, promising a new era of minimal invasive solutions with optimal outcomes. So I thank you for your patience listening. And one of the message which I want to give is teamwork turns small steps into giant leaps. So it's my team. I thank Dr. Bhupinder, Dr. Suraj, Dr. Malli for encouraging me to do mix. I thank Dr. Dilrag, who was the initiator, who set up patients for me, then I go for. And more than that, my anesthetist, Dr. Gigal, Dr. Gopal, because without them, we cannot take these small, small steps. Thank you very much. So any query, any?
Because there is a steep learning curve for this particular technique. But if we look at the present scenario of coronary artery disease, there is more and more percutaneous intervention going on in left main also. But we know from previous studies and data, the left main intervention, if we are doing left main, ostial LAD, say even leave apart the left main, the ostial LAD, the results are not good, even with the stenting. So this becomes a very important technique or the intervention which is minimally invasive. You can always guide the patient that if you want to just put in a stent, you can just guide it. The surgery is going to be very risky and it is going to give you a big scar. That's the usual way we as cardiologists, you can say I'm a cardiologist. So patients are more towards getting the PCI done. But if you offer them, this could be one of the options. So, and the results will be far better compared to the PCI. So patients might be, going towards the CABG option, which is like this particular option. And obviously, this is not a scenario when you have a triple vessel disease, like RCA is also involved. Minimally invasive, as sir has told, you can go for LAD graft and the circ graft as well. So if you have a distal left main, ostial LAD, rather than stenting, you can go for a minimally invasive surgery. That's a better alternative for the patient management for the long-term outcome. Thank you.
Sir, there is my question, a small question. Sir, now we are promoting that we can do the this bypass surgery from the minimal invasive process. So what the common public, they think that now there is no need for the big incision and all surgeries can be done. So are you selecting some of the cases for this minimal invasive, or it can be done in all cases?
I think, as I told you, Dr. Akhilesh, see, all cases are not fit for this minimal invasive approach, although there are groups who are doing minimal invasive surgery in all the vessels. But there again, mortality is more. You have to be very clear or very clear in your mind, and your conscious should be very clear what you can do and what you can offer best, where you decrease the mortality. You want to give relief to the patient. So in my extensive years of this thing, yes, I've started out very late this procedure. One should be cautious in offering what you want to do. Like Dr. Bhupinder said, proximal left main, ostial left main. Now, in a corporate setup, I am not pointing towards Dr. Shiba because we were part of the same group. In a truly corporate setup, वो क्या हो रहा है? Oh, नहीं, मैं stent डाल दूंगा. Already there is a heart attack. So family sari, they are stunned. You have to explain. And I'm very happy that Dr. Bhupinder, Dr. Suraj, a whole group, they explain these are the benefits. You have to be bold enough to say that these are the benefits. And I have not done few cases where I've told them to go for stenting, even osteoproximal LADs, or sometimes I tell them, okay, this patient is sick, this patient not fit for surgery, go for stenting. So you have to select. You have to be very selective.
Thank you for your comments. So you would agree with me, Dr. Rajiv, sir, that though the system is corporate, but we always deal our patients with a heart and zeal and ethics that is very much imperative to them at any point of time. And we did it together always. So another thing which came to my mind, especially when Dr. Bhupinder mentioned about the scar, I recently mentioned about the study which we had published in Heart Asia. And one of the important, in fact, I said it also the last when I was speaking, that the scar is very important, especially especially for female patients. One of the reasons for not getting the surgeries done, even free of cost, in the women was the scar. And this was not just reported in our study in Heart Asia, this was also reported by Dr. Ramakrishnan. They did a similar study at AIIMS, and they found that scar was one of the issues. And I know that you've always been very fond of it. You used to do ASGs and other. So I think minimal invasive is the requirement wherever feasible by the indications. So thank you.
Thank you, Rajiv, for an excellent talk. And again, I think AIIMS is a premier institution where it is being done economically, and we need to generate awareness among people that more and more people can come here. And I can vouch for Dr. Shiba's corporate culture. I think DMC doesn't have corporate culture, because I know each and every cardiologist matlab, very closely. So maybe corporate culture may fit in on another hospitals, but not on your group. Dr. Papinder is also there. For I think DMC products have different label, non-corporate, corporate label. So
That's
thank you very
why,
much.
sir, I've excluded, I said Shiba should not take offense to that because we were part of that group. And that group runs in our veins, our arteries. Thank you very much.
Thank you, sir. Thank you. Now I invite Dr. Neeraj Nagpal